Hello, and thank you for joining today's webinar on first trimester ultrasound. Guideline-based approach includes the diagnosis. My name is Kathy Elliott, and I'm the Marketing Director for Women's Health Ultrasound at GE Healthcare, and I will be your moderator for today's webinar. And now, I'm honored to introduce our esteemed presenter this evening, Dr. Reem Abu-Rustam. Dr. Abu-Rustam is an associate professor at the University of Florida and serves as the Director of Ultrasound Services, Education and Research in the Division of Maternal Fetal Medicine. She is also the president-elect of the International Society of Ultrasound and Obstetrics and Gynecology. Her clinical interests include ultrasound, specifically the first trimester fetus and the fetal heart, ultrasound education, and global outreach. Please join me in welcoming Dr. Abu-Rustam.
Thank you, Kathy, for this introduction, and I'm truly honored to be here today. I would like to thank GE for giving me the opportunity to discuss first trimester ultrasound, a guideline-based approach and clues to diagnosis. During this presentation, I hope to highlight the importance of assessing the fetus at 12 to 14 weeks. I would like to go over the constituents of the AIUM and ISWOG first trimester guidelines. I will talk about the various markers that allow us to detect certain anomalies at this point in gestation and, of course, highlight the many limitations. I will start with a background, then go into the constituents of the guidelines. I have selected specific clues to go over with cases, talk about the limitations, future direction, and end with conclusions. The main instigator for what we do today is the nucal translucency. And this dates back to Langdon Down to 1866, who first described the fetus with Down syndrome as having skin that is deficient in elasticity and a nose that is small. In 1985, it was Professor Benasarov who first described the nuchal fold as a second trimester marker for Down syndrome. And 7 years later, in 1992, Professor Nicolaides talked about the nuchal translucency, and this is what has revolutionized our practice today. I would like to highlight that between 1992 and 2011, we had about 70% of pregnancies presenting for NT assessment at this point in gestation. Of course, this was prior to the introduction of NIPS, and this brings me to the very important point that congenital malformations are nearly 7 times more common than chromosomal aberrations. This is why it is so important not to lose access to fetuses at this point in gestation. Now, since the introduction of the NT, this has been coupled with tremendous technological advances. And really, with the equipment that we have today, we are able to study the developing fetus with so much detail and at much earlier points in gestation. We are able to look at the vasculature, and we are able to study beyond structure going into function. Now, why should we detect early, and what are our main considerations? First and foremost, our patients wish to know. This gives us ample time for workup and to discuss options with families. In addition, in utero therapy is available at various centers of excellence depending on the underlying congenital malformation, and this will allow us to complete a workup and make arrangements for our patients. There are legal limits for termination across these United States, and we certainly have been under a lot of pressure here in my state of Florida. If the patient were to elect to terminate, it is safer the earlier that it is done in pregnancy, and if they were to continue on with the pregnancy, this may allow us to explain sudden in utero fetal demise. It also allows us to study the natural progression to certain conditions. It is helpful in the high BMI patient because it gives us an access under the pannus or transvaginally. It has psychological ramifications, impacts our obstetrical care, and is undoubtedly a very powerful tool for early reassurance to families who have had prior affected children. Now, having a protocol is so important, as has been shown by Karim in 2017, whether it is for major anomalies, all anomalies, or those in the high-risk patient. And this brings me to today's guidelines. The first guideline we had was from ISWAG in 2013, and this has just been revised in 2023. AIUM put out its first trimester practice parameter, and this was led by Professor Bromley in 2020. And this is primarily what has been used here in the United States. But let us look and compare both of these guidelines. I have highlighted in red the main differences, and I will go into various components of the guidelines. Now, the first thing is both of them have as a primary goal aneuploidy screening, establishing dating and chorionicity, and the detection of structural anomalies. The ISWAG guidelines highlights obstetric complications more than we have in the AIUM. Now, there's a slight difference in when you can start doing this examination. For the AIUM, it starts at 12 weeks. For ISWAG, it is 11. The main reason is for the AIUM, this is for structure. This is since the introduction of NIPS. And of course, the further we are in gestation, the better our ability to detect structural abnormalities. On the other hand, if you're not using NIPS and you're using the NT for aneuploidy, then the earlier you are, the more sensitive is the NT. Now, we require advanced training for the sonologist and high-end equipment with high-frequency probes and, of course, proper documentation. One of the critical components of both guidelines is the adherence to the ALARA principle, though there is a difference in the output display standards, and I will talk about that shortly. In the US, because of a limitation in centers of expertise, this is indication-driven, whereas according to ISWAG's guideline, this is to be offered to everyone, and if the center is unable to perform it, to refer. Both stress the importance of determining chorionicity and amnionicity in multiple gestation and screening and counseling. As I mentioned before, ISWAG puts more importance on screening for obstetric complications than the AIUMs, highlighting the role of biochemistry and various analytes. Sonographically, AIUM uses the coronal plane more than what we will see in ISWAG's parameter, and both of them have roughly 30 anatomic and biometric planes. Now, the AIUM guideline, it has a required component, and then if there is an abnormality or based on certain findings, there are additional requirements as indicated. The ISWAG guideline, on the other hand, has a basic and an advanced section, and this is based on the experience of the sonologist, and so as expertise is gained, the center can transition from performing the basic to the advanced. Now, there are several goals to performing a scan at this point in pregnancy. First and foremost is safety. And this is why you have to be mindful to the output display standards. There is a difference between AIUM and ISWAG. According to ISWAG's safety committee, they recommend that the thermal indices should be less than 1. AIUM, however, stipulates that it should be up to 0.7, so be very mindful to your output display standards and be observant not to exceed 0.7. You have to start by determining the location of the pregnancy. So is this a properly placed intrauterine gestation? If there is a prior C-section, where is the scar? Is there any concern about the niche? And I will show some interesting cases that we've had in the past year. First is a heterotopic pregnancy where you can see a gestational sac that is within the endometrial cavity, but then we do have another heterotopic gestation in the niche. Be careful of a cervical ectopic, and most recently we had a very healthy intrauterine gestation where you can see the fetal pole and the yolk sac with the subchorionic hematoma. However, there was also a heterotopic gestation that was intramural. This soon resorbed within a few weeks after this scan. Viability is very important, and we need to use M mode to measure the fetal heart rate. If you are worried about having a live fetus, color may be used, and in this case, we had a dichorionic gestation with the demise of one twin. Number of fetuses is much easier and to determine in the first trimester and to establish chorionicity. If you are very early on in a monochorionic gestation, it becomes difficult to see a dividing membrane. Use the transvaginal route and you can count the yolk sacs. Dating is also a very important component of both guidelines, whether you use the CRL. This is also important in case of twins because early discordance in the CRL and in the nuchal translucency, especially in monochorionic gestations, is associated with twin-to-twin transfusion syndrome. Screening for aneuploidy in the era of NIPS is not our priority, and the AIUM guideline does not stipulate measuring the NT, especially when NIPS has been done, but to look at it, and if it looks increased, to measure it. But certainly the nuchal translucency, looking for tricuspid regurgitation, and reversal of the A wave in the ductus venosus are key components in screening for aneuploidy. In terms of detection of structural abnormalities, the guideline-based approach for both is very similar to what we do in the second trimester, where we evaluate the fetus using the sagittal, axial, and coronal planes. In addition to the biometric component, we look for the placenta and cord insertion. We look for all the axial planes of the fetal head. We look at the fetal face coronally and sagittally. We look at the fetal heart, the fetal abdomen and pelvis, and of course, the fetal skeleton. Now, I've combined in this table all the possible structures that can be assessed at this point in gestation from both guidelines. And as I mentioned before, create your own protocol in your unit and add components as experience is gained. When we start with the head and brain, we're going to do exactly what we do in the second trimester. We're going to look at transventricular, transthalamic, and transcerebellar planes. We want to look at the shape of the skull, make sure there's good ossification. And as we sweep through the head, we will start by looking at the butterfly sign. This was described by Sepulveda in 2004. This is formed by the choroid plexus at the transventricular plane. And you will see that in the first trimester, the choroid plexus proportionately is much larger. It occupies a bigger area within the skull, and it touches both medial and lateral walls of the lateral ventricle. The reason for this is it plays a key role in secreting growth factors, interleukins, and cytokines, and in this way, it creates short diffusional distances to get them to the developing CNS. Below it, you're going to see your thalamic plane, where you see the thalami, the midline folks, the cerebral peduncles, and with good resolution machines, you can see the aqueduct of Sylvius. And I say usually it's almost a third of the way from the occiput inwards, so it is kind of a mirror image of where our CSP would normally be. That is the aqueduct of Sylvius, not to be confused with the dilated fourth or the third ventricle. And above our transthalamic plane, you may see a fluid-filled structure that in some early guidelines was referred to as the third ventricle. In fact, this is now known as the cavum villi interpositi, which is a physiologic fluid collection seen suprathalamic. The cerebellum may be seen and measured, and this depends on the route of scanning and the resolution of the equipment. Now, with some of the new techniques, it is also quite impressive, the details that we can see within the brain. And this is an example of the brainstem, so clearly seen on a fetus at about 13 weeks. Moving to the face and neck, we start with the plane where we usually measure the nuchal translucency, and there are so many critical components to this plane that I will highlight in a minute. So we look at the face sagittally. and coronally, because coronally we can see the orbits, we can see the retronasal triangle and the mandibular gap, and I will discuss their importance shortly. We can also look for jugular cysts. We may see the ears and assess their level as well. Now, the mid-sagittal plane is one of the most critical planes throughout pregnancy because it has so many markers within it, and this is a plane that we're credentialed in for nuchal translucency. A lot of times you may think that the image on the left is a true mid-sagittal plane, where in fact it's not, because you see here a communication between the maxilla and the nasal bone. And this is the frontal process of the maxilla and should not appear if you are truly mid-sagittal. So now that we've established a true mid-sagittal plane, and we know this is where we measure our NT, this is where we can also look at the continuity of the skull and see the frontal bone. We can see the equal sign, the nasal bone. We can see the maxilla, that it's nice and continuous and well ossified. We can see the mandible. We can see the thalamus. We can see the sphenoid bone, the midbrain, the brainstem, the medulla oblongata, the future fourth ventricle, which has been coined the intracranial translucency, and the asterisk is on the choroid plexus within the fourth ventricle. We can see the cisterna magna and the occipital bone. Now, as we sweep coronally on the face, we are able to see the orbits and the lenses. We're able to see the retronasal triangle and the mandibular gap, and I will cover their details in the next slide. And we can see the upper lip, and this becomes very important to families with a prior child with a cleft lip. Using 3D will help reassure them even further. Now, the retronasal triangle was described by Sepulveda in 2010 as a means to assess for facial clefts. And the components are the two nasal bones, the frontal process of the maxilla, the primary palate. This is where we also see the two edges of the mandible with a gap in between to help rule out micrognathia. And of course, if you sweep coronally, you will see the orbits and the lenses. Now, the maxillary gap was described by Shawi in 2015 as a marker for facial clefts. It should be continuous, it should be without a gap, and if there is a gap, that gap should be less than 1.5 millimeters. Moving to the thorax and not the heart, you have to assess the ribs and the rib cage. You need to make sure your lung fields are normal in appearance, and of course establish situs and where the heart and the cardiac axis are. And coronally, you are able to see the lung fields, and you're able to see the diaphragm and the demarcation with the abdominal contents. With new equipment, we're able to see the differentiation of the organs with so much more clarity. You can see the lung fields here, but look at the difference with the liver. You can see the spleen, you can see the stomach, you can see the kidneys with the renal pelvises, and utilizing color will allow us to see the renal arteries. Now, the heart is one of the most critical structures for us to evaluate. The key planes for screening at this point in pregnancy are the four-chamber view with and without color, the three-vessel trachea view, and the sagittal views. And we can see so much with proper magnification, and I need to highlight how important it is to magnify. Because if you look at the image on the right, the heart at 12 weeks is really the size of a rice grain, and at 20 weeks it becomes the size of a euro coin. And so without proper magnification and high resolution probes, we are not able to see it properly. Now, we start with a four-chamber view with color, and one of the most important things to measure is the cardiac axis, which was described by Sinkoviskaya in 2010. We measure it as we do in the second trimester by bisecting the chest and putting a second line over the interventricular septum. This angle should be between 30 and 60 degrees, so it is stable throughout gestation, roughly at 45 degrees. And what they have shown, Sinkoviskaya's team, is that this outperforms the nuchal translucency in screening for congenital heart defects, especially if they are isolated, not part of a syndrome, and especially if they involve the outflow tract. we need to see the three-vessel trachea view, and the V sign has been described as another marker to assess for abnormalities. And with the new resolution of the equipment, you can go up higher than the three-vessel trachea view. You can go up to the thigh box, where you can see the thymus bordered on either side by the internal mammary arteries, and you can see the brachiocephalic vein posterior to that. So we can see a lot of detail in all of these axial planes. Looking at the four-chamber view with the three-vessel trachea view will allow you to screen for over 85 to 90% of major congenital heart defects. Now, as you sweep up from the four-chamber view, you see your three-vessel and three-vessel trachea view, but you can also look at sagittal views. Before we get to that, actually, with new color schemes, we can see the pulmonary veins and a lot of the vasculature within the lung fields themselves. We can see the aortic arch, we can see the ductal arch, and we can see the bicaval view and a lot of the venous system using different techniques. And using glass body, you can see here that we clearly see the bicaval view, the right atrium with inferior and superior vena cava. We see hepatic vein, umbilical vein. We see the azygos, and again, using different color schemes and glass body modes. Moving to the abdomen, we're able to look at the abdominal circumference plane where we measure the AC. We can see the renal arteries, and these are very helpful in ascertaining the presence of the kidneys, because a lot of times we may not be able to clearly see kidneys depending on the gestational age and the resolution. We can also see cord insertion, and we can also see the bladder with a three-vessel cord. And employing color, you can see the hepatic vasculature, and you're able to see cord insertion as well. Now, without color even, you are able to see cord insertion into the placenta, and as we sweep up on this fetus, you can see cord insertion into the abdominal wall. You can see the renal pelvises axially, and you can measure them, and they should be less than 2.5 millimeters. And of course, as I mentioned earlier, looking coronally, you can see the kidneys and the renal pelvis very well with the renal arteries that allow you to make certain that you have kidneys there. Now, when you look at the bladder and you can see the bladder with a three-vessel cord, be very careful not to immediately tell the patient you have a single umbilical artery. These vessels are very small, and many a time, depending on your angle of insonation, you may only be able to pick up one vessel. We can also see the rectum, and you can see the structures in between and this distance, whether it represents a uterus or not. Now, the spine will vary depending on the gestational age because of the ossification centers, and you can see the intactness of the skin. You can see it sagittally, coronally, and transversely with 3 ossification centers very nicely here, but of course there are limitations at this point in gestation. Vaginally, you may be able to get much higher resolution, and you can employ 3D to look at the rib cage. You can see here the scapulae, the clavicles, and you can see the iliac crests. The extremities are much more easier to assess in the first trimester. You can see all 3 long bones, the humerus and our radius and ulna. You can see the lower extremities, and sweeping through, you're able to see the feet moving, and you can see even the popliteal vasculature. And looking at the upper extremities, you're able to see all long bones, you are able to see the hands and the fingers. Now, 3D is helpful because usually the fetus puts the hands and feet in front of the body to ascertain their presence, versus second and third trimester, where we really struggle sometimes to look at the extremities. Now, with new equipment as well, it is amazing how much we can see. As I sweep down this fetus, you're going to see the clavicles come into view very clearly. And what is amazing too is our ability to see the muscles, and this is becoming more and more obvious with the resolution and the equipment that we have today. And I wonder whether our next areas are going to be the musculoskeletal system with a focus on the muscles, because look at the clarity with which we see so much of the thoraco-abdominal musculature. And this will be a whole new level of learning. As we move into the pelvis, we need to look at the placenta as well, and we need to look at the cord insertion and make sure that we have a proper cord insertion. In this example here, you will see that the cord inserts directly into membrane, and using color, you can see it very clearly as well. This was a filamentous cord insertion, and these can be seen as early as 12 weeks. This is a recent case of monoamniotic twins, and on 2D, you can see the entangled cords already, and using 3D, you can see that you have cord entanglement. And so in this case of monoamniotic twins, those are very important things to look for and to follow through. Now, amniotic fluid and membrane are very important as well. Though we don't measure the AFI at this point in gestation, you can subjectively assess it, and you can look at the amnion and make sure you don't have synechiae or any bands. As you can see here, this was a case of an amniotic band through the fetal face, and you can see the difference in the ecotexture of the fluid around this massive disruption and the deformity. Now, the maternal pelvis is part of the guideline as well. You have to make sure there are no large myomas, no Müllerian anomalies, and no masses on the ovaries. As we see here was a case of a borderline tumor with microinvasion at the time of the first trimester assessment. Next is screening for obstetric complications, starting with PAS. And you can see in this case, of course, this is transvaginal. You have the cervix here. You have a placenta previa and anterior previa, no clear demarcation with the uterus, and you have increased vascularity at the interface as well. And this was a PAS. There are many other examples, some of which include looking for your cesarean scar. And in this case, you can see the C-section scar. You can see the extension of the chorionic plate into the C-section. And this was a niche pregnancy with extensive vasculature at the bladder interface. Now, for screening for preeclampsia and preterm birth, there are various calculators available through the Fetal Medicine Foundation. They require sonographic indices, maternal characteristics, in addition to various serum analytes, and those are highlighted specifically in the ISWAG Advanced Guideline. Now that we've covered most of what is available in both guidelines, we're going to go to clues to diagnosis. And there are so many hidden markers that have been described. I have them listed alphabetically here as to the marker, the organ that it corresponds to, and what we may use it to screen for. And for the purposes of time, some clinical examples of. So we will start with the butterfly sign, and this is what we saw as the normal. And as we sweep through this fetal head, this is anterior, this is posterior. You clearly see a little bit of the choroid plexus, no butterfly. There is a monoventricle here, and this is a case of holoprosencephaly. Now, moving to the cardiac axis, you can see the normal on the image here, an angle of about 45 degrees. And we had this fetus who presented at 12 weeks, 6 days with an axis of 99. And trying to sweep from the 4-chamber view to the 3-vessel trachea view, we didn't have a very nice 3-vessel trachea view. And there is an area at the crux where you almost see communication. And so the patient was counseled and brought back in about 2 weeks. And this is that same fetus at 15 weeks, 3 days, cardiac axis still at 89. And watch as we sweep up in this heart, you clearly see a membranous VSD with an aortic override. And this was a case of tetralogy of Fallot. So the cardiac axis was key to this diagnosis. diagnosis. And this is a more recent case where, again, looking at the grayscale, you will see left axis deviation with a cardiac axis of nearly 90 degrees. It looked like there's a VSD, maybe an override. And again, as we look at this clip, you will clearly see that we do have a membranous VSD with an aortic override. This is another case of tetralogy of the lobe. Now we move to choroid plexus cysts, and we have to highlight that these are a more common occurrence the earlier we are in gestation, and they do tend to resolve. We see them a lot in the early second trimester, but in this first trimester fetus, they were really quite impressive and large. And here is a 3D of them. We followed this fetus. NIPS was negative. There were absolutely no other findings, and they did resolve with a healthy neonate at birth. But those can be significant, and so watch and follow. The ductus venosus is a very important structure in the fetus, not only for screening for aneuploidy, but also as a marker for complex venous malformations. And what I have on the left is normal venous system, where you see the right atrium, you see the inferior and superior hepatic vein, the ductus venosus. And one of my astute sonographers was scanning the first trimester fetus, and she kept getting this circular vascular ring and could not get what we normally see in terms of ductus venosus hepatic vein, but rather this very striking circular vascular ring. And this was a portosystemic shunt that was picked up in the first trimester. Okay, next we're going to go to the gastrointestinal tract and the evanescent pelvic translucency. And this is the case that made my sonographers believers in the first trimester scan when I first joined them in 2018. As my sonographer was attempting to measure the nuchal translucency, a nuchal cord was seen, but her eyes drifted to the pelvis, where there was an oblong cystic structure that she measured. Now, this was described by Jean-Philippe Beau in 2010 as an echolucent area that appears in the first trimester, but disappears in the second. And the fact that this appears highlights that it may be a marker for anal atresia. This fetus did have anal atresia. Now, we recently had another case. I did counsel the patient about anal atresia. The fetus is still in utero. We're following closely, and we'll see what the outcome is, but certainly be mindful that appears and then disappears. Next, I'm going to talk about the max section on the face. As you're looking mid-sagittally, you should see a nice and continuous maxilla. And here we see two different fetuses where the proximal half of the maxilla is missing, and this is a cribiform maxilla. Both had a very large facial cleft. And in this case, this is another fetus. Looking coronally at the face, you cannot see a retronasal triangle, and you will see a large defect in the upper lip of the fetus. This was a cleft lip and palate. Moving to the genitourinary system, we can see a large cystic structure and the abdomen in this case, and it does communicate with the kidney on the right. And so this was a megacystis with a hydroureter, hydronephrosis in a case of bladder outlet obstruction. Next, we're going to talk about the nuchal translucency. Even though it is an established marker for aneuploidy, it has a role in congenital heart defects and various syndromes, as I will illustrate. This is a recent case with a fetus that had a nuchal translucency above the 99th centile. And as we look axially here in a second, you are going to see the thick nuchal translucency with septi. And as we get into the neck, we're going to get jugular sacs on both sides, and you can see them here on both sides. Also parasagittally, you can see the jugular sacs, and using biplane, we can look at the fetus both sagittally and axially, and you will see that you can put your marker where you're looking, starting with the nasal bone and the retronasal triangle, going up to the level of the butterfly, and walking down the entire fetus to look at the face, orbits. You can see the chest, the stomach, established situs, and all the way downwards. This fetus did not have any other abnormalities, but it was a case of Noonan's. And this next case, yes, it is clear that we have a very thick nucal, but there is much more than that. You can see that this fetus is hydropic with skin edema, with very large pleural effusions, and with multiple septi and jugular sacs. And this fetus had Turner syndrome. Next, we're going to move to the three-vessel trachea view, although I did touch on that when I talked about the cardiac axis. This is a case where we were sweeping from the four-chamber view to the three-vessel trachea view, but we kept getting this circular structure. And instead of getting a V sign, we have a U sign here, which has been described with a right aortic arch, with the trachea being in the center. However, as we continued to adjust our color settings, we could see a vascular ring circumferentially around the trachea at this level, and this is using 3D. This was a double aortic arch. Next, I will talk about tricuspid regurgitation as a marker for aneuploidy and congenital heart defect. And it's clear the minute you look at this heart, the cardiomegaly that we have, the left axis deviation. And to orient you, this is spine, this is anterior, these are the ribs, and here is the septum, and I've labeled right and left. And so you clearly see a very large right ventricle and an even larger right atrium, very small left atrium, and you can see the regurgitant jet even without color. And using color, you will see the regurgitant jet emanating from deep within that ventricle, and this was Epstein's anomaly. There are many limitations as we transition now into this very important section to keep in mind as you start looking at fetuses at this point in gestation. Primarily due to the fetal size, this requires training, high-end machines. We are limited by maternal BMI, though under the PANIS and the transvaginal route give us another option. We're limited by the developmental stage of the fetus. This can be time-consuming, and it may cause undue parental anxiety. The highest challenge, the greatest challenge, is with the low-risk patient. So my final message is one of caution. Be careful as you interpret. Be careful. Bring patients back. Double check before you alarm them. And I start with this example at 9 weeks, 5 days, where it looked like there's an omphalocele. Of course, we know that there is a normal exomphalus at this point in gestation. Bringing the patient back 3 weeks later, sweeping down, you're going to see here in a second that we have an intact abdominal wall with a normal cord insertion here, and this is physiologic gut herniation. In addition, this is another case where we were worried about the ossification at 11 weeks, 3 days, where you can see the terms of the skull, certainly not much in terms of the rib cage or with the vertebral column. And there was concern, is this a skeletal dysplasia? Well, just 10 days later, look at this fetus, a very well ossified skull, a beautiful spine, rib cage, and so this is clearly just a developmental limitation. Now, this case, you worry about any kind of a cleft in the face, but it is shadow artifact, even though it's a little hand with little. And this was a case on very old equipment from 2010, where at 13 weeks, there was significant ventricular disproportion with a seemingly hypoplastic left heart. However, following this fetus to 21 weeks, we had normalization of the ventricles, and all this fetus had was an ASD primum with a cleft in the mitral valve. And this case shows that the first trimester scan really can be a double-edged sword because you see things, yet limitations with others. And looking at this fetus, trying to get the butterfly sign, you can see that there is a normal midline folks, but there is a cystic structure lateral ventricle. And here it is on sagittal view, where you can see it as well. And our diagnosis and suspicion was that this is an arachnoid cyst, which indeed it was. Well, if isolated arachnoid cysts have a very favorable prognosis, but they can be associated with agenesis of the corpus callosum. And this is what we could not assess at 12 weeks. The patient had to wait several weeks before we could look at the brain in more details, and this was very anxiety-provoking. And this was a recent case where we had a thick NT over the 95th centile. We had a 2-vessel cord and a seaming omphalocele with a membrane covering bowel. And as we swept down on this fetus, you could see the thick nuchal translucency with some septi. There was no abnormality in the CNS, but we will see jugular sacs appearing here shortly. And there was a VSD. And with these findings, we counseled the patient about the possibility of a chromosomal aberration, thick NT, 2-vessel cord, suspected omphalocele, VSD, and she came back for an MU at 16 weeks, 3 days. And here, as we sweep through, you will see that when we're going to get to the abdomen, there is no longer any membrane covering, free-floating loops of bowel, and here they are, and they are tethered here, and so is the fetal right arm, where we can see a hand but no real fingers, and this in fact was an amniotic band sequence. Future, where do we go from here? I hope with all of this that those of you who haven't started looking at the fetus will start. This is going to be the cornerstone scan for us going forward. And I suggest that you start by the sagittal sweep as you scan your patients, and just save this as a clip and look at it later on. So this is where you measure your CRL. This is where you look at the intactness of the cranium. This is the plane that we're credentialed in to measure the NT. This is where we can also see the frontal bone. We can see the nasal bone. We can see the maxilla in all its intactness. We can see the intracranial translucency, which is the future fourth ventricle. That is a marker for spina bifida. As we sweep, we can see parasagittally the diaphragm, we can see cord insertion, bladder, and stomach, and we can see the phallus, and we can see the extremities. And adding color, we're able to see the venous system, we're able to see hepatic vein, ductus venosus, the aortic arch, we're able to see head and neck vessels that will appear later on. So critical information in this one sweep with and without color. Add to that an axial sweep. You start with the butterfly, midline folks. You're going to see orbits, retronasal triangle, mandibular gap, 3-vessel trachea view, 4-chamber view, axis with situs, cord insertion, bladder, and extremities. In addition, this scan has a big role in sonoautopsy. A lot of times when we have fetal demise at this point in gestation, if they were to undergo a D&E or induction, we are not able to really determine because of the fragility of the tissue. So ultrasound plays a significant role. This is a recent case that came in with demise at 13 weeks. This was her first scan with us, a suspected abdominal wall defect. And the patient agreed to a transvaginal scan, which was truly invaluable because you will see the extent of this defect with clear amniotic band causing major disruption, malformation with herniated bladder, bowel, and liver. We could not determine the status of the heart. Could this be a pentalogy of Cantrell? And in the first trimester, you can fit the entire fetus in a single volume, and from it, you can obtain all the anatomic and biometric plane needed for a full assessment. We looked at this back in 2012 and established the distances between these planes. And now with the advent of AI, imagine what we can do in the first trimester with a single volume. This is a most comprehensive, recently published paper on artificial intelligence in obstetrics, highlighting what has been done in the first trimester. Again, very little in comparison to other points in gestation, and so much more information in one volume. With new technology, we're being pushed earlier and earlier. This is at 10 weeks, 4 days, and so embryo in the future. So to conclude, I hope I've been able to highlight how important it is to perform a scan at 12 to 14 weeks, adhering to the guidelines that we have, adapting them for your unit, and of course, being mindful to all the safety recommendations. There are so many hidden markers that we can look for, and really the future has unlimited potential. None of this would be possible without the incredible team that I'm blessed to work with, the MFMs at the University of Florida, my MFM fellows, my genetic counselor, and of course, at the forefront of which my sonographer extraordinaire, Cam, and the incredible team that she has amassed with their skills, because the sonographers are really our eyes and brains with each scan. I see what they show me and what they really suspect. We have an amazing team with our coordinators, and I thank you for your attention.